A very good morning to all of you. So we welcome you again this Sunday with another webinar of our webinar series. And as usual, we have our housekeeping rules for the day. And mostly I would like to inform you that today, since we are having two programs running simultaneously, we are conducting also the EBA lecture series. We have a limited participation available for the Zoom webinar link, but we will be live streaming our webinar on Facebook, and I will post the link on our chat box. Please share it with your friends and all other colleagues who cannot log into today's webinar. So without further ado, I would like to tell you that today we have a very important topic and a very interesting topic. For the housekeeping rules, the webinar link will be available from 9 a.m. to 9:45 a.m. for all of you to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And these CPD points are highly regulated, and we thank you for your generous and very consistent participation in our lecture series. Other than that, we would also kindly request all of you to switch off your microphones and keep your video on off so that there will be no interruptions during the webinar. Other than that, our chat box will always be open to entertain all your questions, and we will be able to discuss with them with our distinguished guests today at the end of the series. And the e-certificate will also be issued today. And at the end of the webinar, we will be posting a link for the post-evaluation questionnaire and the e-certificate. Today, we are talking about a very timely and important topic, the ABCs of dengue. And to introduce our distinguished guests for today's lecture series, I would like to invite Dr. Himal. Over to you.
Good morning, everyone. Thank you, Dr. Romali. Welcome to another important medical sessions in Sri webinar series. Today, our topic is ABCs of managing of dengue fever. Let me remind you, this is another session, the joint teaching session we arranged with Sri Lankan College of Internal Medicine and GMO Sri. Today, our guest speaker is Dr. Raveendran Gajanthan, MBBS, MD, and MRCP. Dr. Gajanthan is a specialist in internal medicine, currently working as a consultant physician at Teaching Hospital, Jaffna. He is a product of Faculty of Medicine, Colombo, and he has achieved his MD at 2015, and he completed his post-MD overseas training at Luton and Dunstable University Hospital in United Kingdom. He is a visiting lecturer in pharmacology, Faculty of Medicine, University of Jaffna. With his years of clinical experience, he would like to talk us about important points in management of dengue patients. Without further ado, I would like to invite Dr. Raveendran Gajanthan to deliver his talk. Dr. Gajanthan, sir, session is over to you now. Thank you.
Thank you, Himal, for your kind introduction. Good morning, you all. First of all, I would like to thank GMOSRI Knowledge Academy as well as SLCM for giving me this opportunity and conducting this CPD program. Today, our topic is the ABCs of dengue. We will start off with the common case scenario. A 23-year-old boy with a 2-day history of fever admitted to Teaching Hospital Jaffna. No nausea, vomiting, or no abdominal pain, no bleeding manifestations. On examinations, blood pressures are stable, 110/80, pulse rate is 76, lungs are clear. Investigations wise, WBC is 4,500 and the platelet is 140,000, PCV is 45, CRP is 5. So it is actually a acute febrile illness. So we should have some differential diagnosis when we're dealing with this sort of case. So the common differential diagnosis we have to consider are dengue fever and other viral illnesses, typhus, typhoid, leptospirosis kind of illnesses. So here, because of the low WBC and the normal CRP, it makes leptospirosis a bit less likely. Likewise, typhus and typhoid also usually present with high CRP, and those are the two bacterial infections usually present with leukopenia rather than leukocytosis. But typhus and typhoid will have high CRP, so that is also a bit less likely. So this is a case of dengue fever or viral illnesses. So those are the two main differential diagnoses we have to consider. Right, with that introductions, we will go into these slides. A small introduction to the dengue fever, dengue virus. This is the commonest type of flavivirus. This is the arbovirus, as the name implies, that the first two letters of arthropod and the first two letters of bone. So that's why it is called arbovirus. There are 4 serotypes. What is the clinical significance of these 4 serotypes? Because one can get 4 dengue infections during their lifetime due to this dengue virus, and usually the second one is the one usually present with the severe form of dengue infection. Right. Then we will see about these dengue mosquitoes. The 2 mosquitoes act as a vector, mainly Aedes aegypti and Aedes albopictus. These are female mosquitoes that bites the humans and preferring to lay down eggs in man-made water containers and resting indoors and feeding in the early morning and the late afternoon. These last 2 features, this resting indoor and feeding in the early morning and late afternoon, makes them relatively immune to the outdoor public health spraying, and it is easily disturbed during the feeding. Because of that, what will happen, they can potentially infect several people during one feed. This is the picture of dengue mosquito. You can appreciate the black and silvery scales on the abdomen and thorax. Epidemiology wise, almost more around 31,000 suspected dengue cases were reported to the epidemiology unit in 2020, but in 2022 up to now more than 42,000 cases are reported. That may be, partially due to this COVID infection. During that time, the dengue cases are not reported properly, and due to some unknown reason, the incidence of dengue fever also low. And around 40% of these cases are from Western province. You can see, as far as the Sri Lanka is concerned, usually we are getting 2 outbreaks. One is from this November to February period, and other one is the June-July period, where the incidence of dengue fever is high. Right. With that small introduction, we will enter into the classification of dengue viral infections. Dengue viral infections can be divided into asymptomatic and symptomatic. Asymptomatic infections goes unnoticed. Only the symptomatic dengue fever will be dealt by the doctors. So the symptomatic dengue infections again divided into undifferentiated fever, or dengue fever, or dengue hemorrhagic fever, or expanded dengue syndrome, or isolated organopathies. First of all, we will see what are the symptoms that commonly happens with the dengue fever. That is fever, arthralgia, myalgia, and bone pain, which are very severe. That's why it is called a break bone fever, and back pain, retroorbital pain, and headache, and some bleeding manifestations also can happen. In addition to that, you should remember that some patients may develop sore throat, injected pharynx, and conjunctival injection. So that's the symptoms of upper respiratory tract infection. And some people, around 1 in 5 patients, dengue patients, may develop diarrhea. So dengue can present like gastroenteritis. It can present like a upper respiratory tract infection, or sometimes the features may be confused with the leptospirosis as well, because of the arthralgia, myalgia, and conjunctival injection and all these findings. So what we have to do is, if the fever persists more than 3 days, it is advisable to check the full blood count and CRP and some of the basic investigations to exclude or confirm this diagnosis. Right. So how can we differentiate the undifferentiated fever and dengue fever? Okay. So actually the undifferentiated fever usually happen with the primary dengue infection. That means when the patient is getting this dengue infection for the first time in their life, usually it present like undifferentiated fever that are usually benign one, even dengue fever also benign one. These symptoms are more prominent in case of dengue fever. And the substantial platelet drops also happens with dengue fever. It can drop less than 100,000, but the viral illnesses, the platelet count usually persists in the range of 100 to 150. So those are the two things, you know, that may help to differentiate, but we can't, you know, 100% confirm or exclude these two conditions because there's an overlap. Right. So then other two important disease entities are dengue fever and dengue hemorrhagic fever. So we will see how we can differentiate these two entities. So the main difference of dengue fever and dengue hemorrhagic fever is presence of leakage in dengue hemorrhagic fever. That is the main difference. Other than that, it is dengue fever usually happen as the primary infections. That means when the patients get this infection for the first time. Dengue hemorrhagic fever usually happen in secondary infection. That means when they get second or third or fourth time. Usually the second time when they get infection only becomes more severe one. And phases of illness, dengue fever does not have this leakage phase. So usually it has only febrile phase and convalescent phase only. But this dengue hemorrhagic fever has three phases: febrile phase for the first 3 days, and then followed by leaking phase that can happen in around 5 to 6 days, the 5th or 6th day, and then thereafter it is followed by convalescent phase. And classification wise, the dengue fever is again divided into classic dengue fever or dengue fever with unusual bleeding that we will see later. And dengue hemorrhagic fever divided into two, with shock or without shock. And the cause wise, usually the dengue fever won't cause any sort of major complication even if we badly managed the patient. But if we are not managing the dengue fever properly, it will lead to multi-organ dysfunction, several complications and death. So we have to be very careful when we deal with the dengue hemorrhagic fever. But you have to remember that at the beginning, so during the early phase, that is during the febrile phase, it is difficult to differentiate whether we are dealing with the dengue fever or dengue hemorrhagic fever. When they develop the leaking phase only, we can say this patient is having dengue hemorrhagic fever. Then hepatomegaly. Tender hepatomegaly may happen with dengue fever, but it's more suggestive of dengue hemorrhagic fever. Platelet drops also usually moderate platelet drops happen, and that is also slowly happening. But in case of dengue hemorrhagic fever, sudden drops of platelets, especially when it drops to less than 100,000, sudden drops may happen, and platelet drops even drops less than 10,000. And pericholecystic fluid in the ultrasound scan. This finding, it is not specific for dengue hemorrhagic fever. It can happen even with the dengue fever, and but if there's progressive accumulations of this pericholecystic fluid, then it is suggestive of dengue hemorrhagic fever. So the serial ultrasound scan will be helpful to differentiate the dengue fever and dengue hemorrhagic fever. Other than that, the evidence of leakage on ultrasound scan in the form of pleural effusion or ascites that is absent in dengue fever, that is present in the dengue hemorrhagic fever. So those are the differences in dengue fever and dengue hemorrhagic fever. And a few words about the leaking phase or the leakage phase or the critical phase. It usually happens on 5th or 6th days, and sometimes early leakage and late leakage happens. And this leakage is a transient leakage, usually lasts for 48 hours. And it is due to the dysfunction of the endothelium, vascular endothelium, rather than the destruction. But in case of bacterial sepsis or something, then it is due to the destruction of the endothelium. So that's why it is a transient, and just after 48 hours, the endothelium regain its normal function. So that's why the leaked fluid will be reabsorbed by the endothelium. Right. So another case history: a foreigner with a 2-day history of fever and hematemesis of around 400 milliliter, admitted to the hospital with a BP of 90/70, heart rate of 110, and he was pale, and lungs were clear, and NS1 antigen positive, platelet at 120,000, and PCV is 40. What is the diagnosis? So what are the unusual features here we have? This bleeding manifestation has happened with the platelet of more than 100,000, and with the fever history of only 2 days. Okay, usually the hemorrhagic manifestations in dengue hemorrhagic fever happens after 3 days with the low platelet count, with the evidence of some leakage. So those are features absent here. Even the leakage is not present here. So what is the diagnosis? This is the case of dengue fever with unusual bleeding. So we will see what is meant by dengue fever with unusual bleeding. So I have just compared these two disease entities, dengue fever with unusual bleeding and dengue hemorrhagic fever with hemorrhagic manifestations. So the patient profile wise, they are from non-endemic areas, that like foreigners, because when they get the disease for the first time only, this disease entity happens. And dengue hemorrhagic fever, as we have already discussed, happens with the secondary infection. So the peoples are from the endemic area. Timing of hemorrhage wise, usually in the first 3 days rather than after 3 days. And platelet count may not be very low. Here usually it is very low. And the mechanism of bleeding is due to vasculopathy rather than the coagulopathy. And in dengue hemorrhagic fever, it is due to coagulopathy. And in very late stages, it may be due to increased fibrinolysis as well. So the bleeding manifestations are usually bleeding into the GI tract. So they will present with the hematemesis or melena. In contrast to that, in dengue hemorrhagic fever, usually they present with the bleeding into the peritoneal cavity. And this hypermenorrhagia, menorrhea, and massive epistaxis also can happen with dengue fever with unusual bleeding. And this is more common in patients who have used to NSAIDs for some other reason as well. Right. So this is the case we have discussed at the beginning of this lecture. So that patient's condition has further worsened. Okay, further worsened, that kind of viral illness picture that has further worsened. Now what is happening? The BP is dropping to 95/70. So the pulse pressure is around 25. Heart rate is increasing around 100. And he is also having right hypochondrial pain, and platelet count has dropped to 60,000, and PCV has raised to 48. So what we have to do here? So the patient condition is worsening. So we have to exclude, or we have to confirm whether we are dealing with the dengue hemorrhagic fever or not. So for that, what we have to do is we have to look for the evidence of leakage clinically. So clinically, what are the features we can, especially we have to auscultate the lungs and see whether their air entry is equal, whether there is any evidence of pleural effusion. Usually the pleural effusions happen in the right side first, then the patients develop bilateral pleural effusion. Then the basic investigations also will help to detect the leakage, especially the raise in PCV, pixel volume, that is 20% raise may suggest the patient is having leakage, or drop in serum albumin level less than 3.5, or drop in non-fasting cholesterol less than 100 also may be suggestive of leakage. Imaging wise, I think that is what we are usually doing. We have to do the ultrasound scan chest and abdomen, and demonstrating the pleural effusions and the ascites or the fluid in the hepatorenal pouch. That will suggest that patient is having leakage. Right. So another worry is whether it is a simple dengue hemorrhagic fever or dengue hemorrhagic fever with shock. So we have to look for the features of shock as well. So what are the symptoms may suggest that the patient is entering into the pre-shock or shock stage after 3 days of illness. Those are sweating, excess sweating, and abdominal pain, and persistent vomiting, and restlessness or altered conscious level, and postural dizziness, and decreased urine output less than 0.5 milliliter per kilogram per hour. Usually, if the patient is more than 50 kilogram person, then less than 25 milliliter per hour is considered as decreased urine output. The signs that is suggestive of pre-shock or shock are cold extremities, prolonged capillary refilling time more than 2 seconds, and unexplained tachycardia, and increasing in diastolic pressure and narrowing of pulse pressure less than 20, and postural drop of more than 20 of systolic blood pressure or more than 10 of diastolic blood pressure. So that is the postural definition of postural hypertension. And if the systolic blood pressure is less than 90 also, suggestive of that. Right, so we have discussed about the undifferentiated fever, dengue fever, and dengue hemorrhagic fever, and then the last entity is the expanded dengue syndrome or isolated organopathies. So where in the absence of leakage, usually unusual involvement of the organs happens, especially liver or heart, kidneys, and the brain may involve. But most of the time, when they develop some organ dysfunction, it's due to multifactorial in case of cardiac dysfunctions, it may be due to metabolic acidosis due to prolonged shock, or it may be secondary to hypocalcemia, or it may be due to myocarditis, but it is a very rare entity, and nowadays they are querying the existence of this myocarditis as well. This demand perfusion mismatch, that is the type 2 MI, usually when the patient develop hypertension, especially in the elderly patients with multiple comorbidities, they can have this type 2 MI, and the other comorbidities also may contribute to myocardial dysfunction. So up to now, what we have discussed is the classification of the dengue fever. Hope you have some idea about the classification of dengue fever. Right. So before entering into other areas, we will just see about this pathogenesis of dengue fever, also dengue hemorrhagic fever briefly. To understand this, you should know what is neutralizing antibodies and what is meant by this enhancing antibodies and their role. So what is neutralizing antibody? Neutralizing antibody, that when a person is infected with 1 serotype of dengue fever, what will happen? They will form the antibodies against that serotype. When the person gets infection with the same serotype, what will happen? The large amount of antibodies will tightly bind that virus and neutralize the virus. So that's why it is called neutralizing antibody. But if the person is getting the infection with another serotype after having this 1 serotype infection and after developing this antibody, if the patient is getting another serotype of dengue virus, then what will happen? So these previously formed antibodies can't neutralize the virus. And paradoxically, it may increase the formation of antibody. So that's why it is called enhancing or cross-reacting antibody. So what will happen? So the viral antibody complexes will be formed, and that will consequently that will activate the complement formations, and these antibodies will facilitate the virus entry into the monocytes and macrophages where the receptor mediated mechanism, and that will ultimately lead to release of large amount of cytokines. So because of this complement activation and the cytokine release, then increased vascular permeability and thrombocytopenia happens that will lead to shock and hemorrhage. So this is the basic pathogenesis of dengue hemorrhagic fever. Right. So we have discussed about the pathogenesis as well. Then we will see, when to admit a dengue patient to the ward. So this is very useful, and we should have a knowledge on that, especially if you are working in the peripheral hospitals or in the OPD setup. So when the platelet count is less than 100,000 in a dengue suspected patients, we have to admit the patients. And even if it is less than 150,000, but the platelet drop is very rapid, drastic drop is observed, then we have to admit the patient. Then if there's any feature suggestive of leakage or pre-shock and shock that we have discussed earlier, the features, the symptoms and signs that are suggestive of pre-shock and shock, if there's any evidence of those symptoms and signs, then we have to admit. And we also have to admit the high-risk patients even in the absence of that above two features, especially in pregnant women and elderly patients and obese patients and patients with multiple comorbidities like diabetes, CKD, or ischemic heart disease, or thalassemia, or other hemoglobinopathies. Again, we have to admit those patients even without those features because they can develop complicated illness. And patients with adverse social circumstances, for example, if the patient is living alone, or if they are living far away from the healthcare facilities, or if they don't have proper transport facilities, then better to admit them for further management. Right, then we will move on to the investigations part. Investigations we are doing for two purposes. One is for the confirmation of diagnosis, and other one is for the monitoring purpose and to support the diagnosis of dengue fever. So for the confirmation part, or to diagnose this dengue fever, we can do some investigation like culturing the virus, or PCR test, or antigen test. Culture we are not doing in our setup. This is only done for the research purpose. The PCR also not widely available. It is very expensive, so we are not doing. So antigen test widely available. So MS1 antigen test we can do, and other tests are that antibody tests. Then we should have some knowledge about this, what will happen just after primary dengue infection. Then that is easy, that will help us to understand about these investigations. So just after primary infections, what will happen, that viremia will drop. It will drop after 5th day, it is almost zero, and then the antibody develops, that is IgM will develop first, followed by IgG, and IgM may last even for 2 months, but IgG persists for longer period of time. So this is what happens just after primary infection. But if the patient develop another infection, that is secondary infection, what will happen? The IgG response will be very drastic, and quickly they will develop, even in the early phase of illness, they may develop very high level of IgG, and sometimes this IgM won't be detected, and the sensitivity of the NS1 and IgM will be low in case of secondary infection. You can compare this IgM spikes in the primary infection as well as in the secondary infection, because immediately they will have the IgG response. So PCR wise, anyway, these antigens are available, or this virus is present in the blood in the first 5 days only. So that's why this NS1 antigen and RNA viruses are, the PCRs are done in the first 5 days of illness. PCR is very sensitive test, more than 99%, even the primary or secondary infection. And the problem is it is expensive and limited availability, but the good thing is it can differentiate the different serotypes, and it will help for the quantification as well. NS1, this is the one we are commonly using. It should be done in the first 5 days, And you can see the sensitivity of the NS1 usually decrease with the secondary infection. You see, compare the primary infection and secondary infection, it is almost 90 to 95. In the secondary infection, it's usually 60 to 70%. With the secondary infection, sensitivity decreases. And even with the primary infection, at the beginning, in the first 3 days, the sensitivity is high, but when it is approached to the latter part of the first week, the sensitivity decreases. So when you are interpreting the NS1 antigen test, you should be aware of these facts, then that will help us. Cross-reactivity with the Zika virus and sometimes with the false positive may happens with the severe sepsis as well. Then IgM antibodies and IgG antibodies are usually done after 5 days. And the IgM sensitivity is high for the primary infection, but relatively low specific sensitivity for the secondary infection. We have already seen why it is happening in the graph, and it will indicate the recent evidence of infection. And again, there is a cross-reactivity may happens with a flavivirus like Japan encephalitis, Western Nile virus, or yellow fever virus, or Zika virus. But the thing is, those viruses are very rare in our setup. Secondary, the IgG also, again, if it is primary infection, we have to demonstrate the 4-fold rise by repeating the test in 7 to 10 days time. In case of secondary infection, as I showed in the previous graph, dramatic increase of IgG happens, so it can go above 1280, that very high titers the patients may have. So the problem happens when the patients present in the 5th day or 6th day. That's a gray period. So in that period, what we can do is we can do the combined test. So NS1, IgGM, and IgG, that may increase the sensitivity to 90 to 93%. So that is some basic idea about these investigations for the confirmation part. Then we will see the investigation that may support for the diagnosis and that is used for the monitoring purpose. The most important one is the full blood count. In full blood count, all these 4 components we have to look at when we are interpreting the full blood count. WBC wise, at the beginning, the patients may have normal blood pressure on day 1. You have done full blood count. That does not exclude the viral infections. Because if the fever persists, we have to repeat the investigations and we have to demonstrate the drop in WBC. Differential count wise, initially the neutrophil count may be high, but when the patients enter into the leakage phase, usually the lymphocytic predominance happens. PCV, of course, as we have already discussed, the PCV rise may be noticed. So it is better to document the baseline PCV. It will be helpful to interpret the consequences. Platelet also usually drops, and in dengue hemorrhagic fever, the drastic drops may happen. Right, few words about this AST and ALT. Usually the AST is more than ALT during the febrile and critical phase for some unknown reasons, maybe due to some muscles involvement or something. Usually the AST is more than ALT in dengue patients. But once the critical phase are over, when the patients enter into the convalescent phase, what may happen? As this AST is having only 1 day T-half and this ALT is having 3 days T-half, this ALT persists a longer time in the circulation. So what will happen? That AST will be cleared quickly. So this ratio may reverse during the recovery phase. That means the patients may have this ALT more than AST during the convalescent phase. And some other investigations may help to differentiate other infection like renal function test, especially in case of leptospirosis or CRP, to exclude other viral infections, bacterial infections, secondary bacterial infection, or infections with the leukopenia like typhus and typhoid, and UFR for the acute febrile illness to rule out the UTI, and ultrasound chest and abdomen to demonstrate the leakage. So those are the investigations will be helpful. So we have finished the investigations part also. Then we will move into the more clinical part, the dengue monitoring. So dengue monitoring wise, there are three kind of charts available to monitor the dengue patients. Depends on the platelet count. If the patient is in before pre-critical phase, so that is more than 130,000, we can use this form, the routine monitoring form. This is the blue one is the pre-critical chart when the platelet drops less than 130,000. But if the patient is not having any evidence of leakage, we can use this chart. And this is the critical phase chart. So when the patient develop leakage, we have to use this chart and we have to monitor these parameters. So what are the parameters we have to use and how frequently we have to use? I have summarized here. So this is in the before pre-critical period. This is during the pre-critical period. So this is during the leakage phase. This is in case of compensated shock or in decompensated shock. So the vital should be monitored at least twice daily, like as for any other patients. Here in pre-critical phase, we have to monitor 3 hourly these vitals, blood pressure, pulse rate, respiratory rate, capillary filling time monitored, and hourly monitoring is needed in case of dengue hemorrhagic fever. But if the patient is having shock, we have to monitor every 15 minutes until the patient is stabilized and while doing the resuscitation. Then urine output in pre-critical phase usually monitored 6 hourly. In dengue hemorrhagic fever usually monitored 3 hourly. If needed, catheterization is also done for easy monitoring. And PCV monitoring, usually in pre-critical phase, we are monitoring 6 hourly. Here we have to monitor 3 hourly. If the patient is having shock before giving boluses and 15 minutes after giving boluses, we have to repeat the PCV. So this is important, you have to remember. So otherwise we won't have any idea, and I will discuss that how important it is later. Then full blood count monitoring, here we have to monitor at least twice daily, and here twice daily or more frequently, depend on the severity, we have to decide. So these are the investigations and parameters we have to monitor in the charts. So PCV is very important parameter that we usually monitor. So we should have a sound knowledge on how to interpret the PCV. So that's why I have put this chart. So while when we interpret this PCV, we should interpret with a clinical correlation. So that's mean whether the patient is having whether the patient is hemodynamically stable or not, in which phase of the dengue fever the dengue hemorrhagic fever the patient is. So those two factors are very important to interpret, and the patient's comorbidities as well. So those three features are important while interpreting this PCV. For example, suppose the patient is having high PCV and patient is in the febrile phase, the reason would be dehydration. If the patient is having high PCV while the patient is in the critical phase, the reason is leakage. But if the patient is a smoker or COPD, okay, the patients may have this high PCV related to his underlying disorder. So for that, we have to see the previous PCV or the baseline PCVs recorded in their clinical books. So that will be helpful because they may have relatively high PCV as a baseline value. Likewise, low PCV in critical phase may indicate occult or overt bleeding. Low PCV in the recovery phase may be due to fluid overload, if we have over-enthusiastic replacement of the fluid, or it may be due to just reabsorption of the leaked plasma may cause this low PCV. Like this high PCV in case of COPD, sometimes the low PCV happens in anemic patient due to whatever the reasons, they may have low baseline PCV values. So it is always prudent to document whether this patient is having any disorders that may alter the PCV in the BHT. Then it will be helpful while we are interpreting the PCV. Right. Then how we can correlate with the PCV and correlate the PCV with the low BP. For example, the patient is having low BP and PCV is high. So that may be due to dehydration or leakage, depends on the phase of the illness. Likewise, if the patient is having low PCV in the critical phase, it may be due to the bleeding. Suppose the patient is having low BP, but the PCV is normal, we have to think whether this patient is having combination of both leakage and bleeding. So that is the worrying feature, isn't it? So with the normal PCV, that may mislead us. We may think that the patient is not having any sort of abnormality, but there is a low BP, no? So that can be explained with leakage and bleeding. Especially it happens in the leakage phase or the critical phase, or when they are in the early part of recovery. And young thin females may have this normal PCV with the low blood pressure, because that some thin females may have the normal blood pressure of 90 or something. But in that case, their volume of pulse would be good. Okay, but if they have a feeble pulse, then again we have to suspect whether we are dealing with these complications. And myocarditis also, even though it's a rare entry, the rare entity that can present with the normal one, normal PCV. Right, so that is something about the interpretation of the PCV and monitoring. And before entering into the major part of this fluid management, we will just discuss something don'ts in dengue fever. So this is very important when you are practicing as a GP or if you are working in the surgical wards or other wards. This NSAIDs and steroids we should avoid in all dengue patients. So don't prescribe for acute febrile illness patients before confirming the diagnosis. Don't prescribe this NSAIDs or steroids because you may be dealing with the dengue fever. So prescribing these NSAIDs may lead to adverse complications when the patients enter into the critical phase. And suppose if the patient is on antiplatelet medication due to some other indication like stroke or ischemic heart disease, it is advisable to withhold the antiplatelet when the patient is having low platelets. And colored drinks also usually avoided because sometimes we can't differentiate whether the patient is actually having hematemesis or it is due to the vomiting out of this colored drinks. And liberal fluid intake during the critical phase we have to avoid because we actually in a systematic manner we replace the fluid during the critical phase. So liberal fluid intake we should avoid. That was the reason for the high mortality before we implement this guideline system in Sri Lanka. Most of the deaths happened due to the fluid overload rather than the dengue fever itself. Right, so the most important part is the fluid management. When we are dealing with the fluid management, we have to concentrate on 4 main aspects. Okay, when we are giving fluid. So what are the things we have to decide when we give fluid? What fluid we are going to give? Okay, so whether oral fluid or IV fluid, if it is IV fluid, what sort of fluid we have to give? Okay, that we have to decide. Then how much fluid we have to give? That is also we have to decide. That depends on whether the patient is in the febrile phase or critical phase, and if it is critical phase, how much fluid already given. All these things will affect how much fluid we have to replace. And the third thing is at what rate we have to give. So in other words, how quickly we have to replace. If the patient is on shock or something, decompensated shock, then we have to give the bolus as soon as possible. Okay, as fast as possible. But in case of febrile illness patients, then we can give 100 milliliter per hour or so. In patients with 50 kilo or more, then we can give 100 milliliter per hour. Then the indications. So if we are giving some fluid like dextran or something, then we have to check whether there is any indications for dextran. Then we have to use the appropriate fluid. So all these 4 aspects we have to consider while we are replacing the fluid or while we are resuscitating with the fluids. So before entering into the fluid quota and all these things, I will just tell why we have to restrict the fluid intake during the dengue hemorrhagic fever. We will just see a some kind of an example I have put here. Suppose this is the normal person. He is taking 3 liters of fluid and output is 2 liters. And insensible loss is 1 liter, leakage is 0. Okay, so 3 equal. Right. If the patient is having this critical phase, the patient in the leaking phase, and patient is taking fluid normally, then what will happen? The intake is 3, and the urine output will reduce, but the leakage may increase, isn't it? And insensible loss same. It's mainly depends on the environmental temperature. So again, when you total these 3, it is equal to 3. If you are replacing to maintain a good urine output with a high volume of intake, then what will happen? Suppose you are giving 5 liters, yes, you can maintain a good urine output, 2 liters of urine output, similar to normal person. Okay, but what will happen? You are increasing the leakage as well, isn't it? At the same time, you are increasing the leakage, so that will lead to adverse complications. So the fluid leakage and the fluid overload will happen when you are replacing with this one. So that's why appropriate and systematic manner we have to replace the fluid during the leakage phase. So if you give 2, then you can maintain the fluid urine output, that is above 0.5 milliliter per kilogram per hour we can maintain, and at the same time so the leakage also will be low. So this is the appropriate one. So to deal with this one, they have proposed a fluid quota mechanisms during the critical phase, that is M plus 5%. So this M is calculated for the 10 kilograms, thousands, first 10 kilogram, next one 500, for the next 31 600. So and 5% division 15 to 50, 2500. So total is 4600. This is for a 50 kilogram person or about that, usually 4600. It is not a big issue. You don't need to remember how we have derived that formula, but you should remember that 4600 that magical value. But if you are dealing with a pediatric patient or emaciated patient, then the weight would maybe less than 50 kilograms. Then these values may differ, especially if it's a 40 kilogram one. Then you have to apply 20 for this one, and here also you have to apply 40 rather than 50 and calculate the fluid quota for the during this critical phase. So during the critical phase, you have calculated that the patient should receive 4600, but we don't know, we are not diagnosing all the patients at the beginning of the critical phase, isn't it? Sometimes we diagnose the patients here, sometimes we diagnose the critical phase here, or sometimes even in the recovery phase also we may diagnose. So that's why always it's better to put this diagram also when you are clotting the patient. So I just draw this one and see. So here the diagnosis was made 12 hours after entering into the leakage phase. We will see how we are diagnosing this one. But this patient was diagnosed 12 hours after leakage phase. So we have to put these values retrospectively. So it was diagnosed on 10th 11 2019 at 10 p.m. Then this one, and then patients will get the maximum leakage at this time and this date, and patients will recover at this date. And when you are clotting the next day, if you are clotting at the noon time, suppose you are clotting after HOS or somebody, then at this line you can see up to now how much fluid we have given. So that is 3600, and you can put the remaining quota also. Okay, that is 1000. So this chart will be very helpful to deal with the fluid management. So how can we diagnose how much time has elapsed by the time we diagnose the patient? So for that, this ultrasound findings and the timing of the leakage is possible. So here, if the patient is having gallbladder wall edema, just a thin rim of fluid only, then that is at the beginning of the leakage phase. But if the patient is having some fluid in the hepatorenal pouch, already 6 hours has passed. And if the patient is having significant fluid in the abdominal cavity or one side pleural space, then almost 12 hours passed. If the patient is having bilateral pleural effusion and ascites, then you can say the patient is at the peak because the leakage is high. And usually when the patients come with the decompensated shock also, usually they are presenting at the peak. Okay, so that's how we put this one. Okay, when we are diagnosing what was the time. Okay, so putting this one would be very helpful based on the ultrasound scan finding. Right, then comes at what rate we have to give. So it's again, if it is February phase, as I have already mentioned, weight into 2 we can give. So for a 50 kilogram or 60 kilogram or 70 kilogram person, we can give 100 milliliter. So if it's a 40 kilogram one, we have to give 80 milliliter. But in case if you are dealing with a critical phase, we may have to adjust the fluid, depends on the clinical parameters and PCV values to match the leakage. So we have to match the leaking rate with the fluid rate. Then only the patients will remain in the hemodynamically stable state. So what are the fluids we can use? For the oral fluid one, if you are using in the February especially, you can use ORS, kanji, soup, fruit juices or king coconut waters we can use. If it is IV fluid, normal saline or Hardman solution rather than 5% dextrose. And colloid, if you are using dextran or if it is not available, tetrastarch 6% we can use, and if necessary we may use blood and platelets and FFP have only limited role, not in the routine management. And we have to avoid colored drinks as I have already mentioned, and avoid the plain water also if possible, because it's not having any sort of electrolytes. And if the dextran, maximum 3 boluses we can give within the 24 hours. And if it is tetrastarch, we can give 5 boluses within 24 hours. So these are some indications for dextran. If the patient is not responding to crystallized boluses, we can use. And or otherwise, if the patient is having fluid overload and high PCV, again we can use. Or if the fluid quota is nearing the completions and we can't use a lot of fluid, so in that case we can use the dextran. The patient is shock and low HCT also, until the blood is the ideal choice. Until blood is available, we can use the dextran. Before giving dextran, it's better to send the grouping NDT. Sometimes it interferes with the grouping NDT, and we have to avoid dextrans in significant renal impairment patients. So those are the 2 things, and don't give dextrans in a patient who is dehydrated patient, because in dehydrated patient, crystalloid are the ideal choice. Blood transfusion, especially in case of overt bleeding, if the bleeding is more than 6 to 8 milliliter per kilogram, then we have to give. In case of concealed bleeding, if the patient is having shock and low or normal PCV, then we may have to give. Or sometimes we don't know the cause, and if the patient is having persistent severe metabolic acidosis with the endogen dysfunctions, we have to give blood transfusion. Okay, right. So when we are giving these fluids, and when we resuscitate patients with the IV fluid, we should know whether the patient is responding properly or not. So for that, I will discuss this slide, then I will come back to that slide. So this is the physiology, basic physiology you would have studied. This is the total body water. This is the intracellular water. That is 2/3 of the total body water is intracellular. These are extracellular, both these 2 components. This is interstitial fluid. This is intravascular fluid. So these 2 comprise the extracellular fluid. This is 2/3 of the extracellular fluid. This comprises 1/4 of the extracellular fluid. So what will happen if you give 5% dextrose for the resuscitation purpose? Then what will happen? It will be distributed in all intracellular and extracellular components. Then what will happen? Only 1/12% only will stay in the intravascular compartment. So that just 42 milliliter will stay inside the intracellular compartment, isn't it? Because it will be distributed in all three compartments. But if you give 0.9% sodium chloride, it is only distributed in these two compartments. So 1/4 will remain in the intravascular compartment, that is 125 milliliters. But if you give dextran, it will be distributed only inside the intravascular compartment. So all 500 milliliters will remain inside the intravascular compartment. Okay. So with that knowledge, we will see what will happen. So when you replace, when you give normal saline bolus, and if you are measuring before and 15 minutes after giving this normal saline bolus, you can demonstrate 2.5, around 2.5% reduction in PCV. Okay. So if you are giving dextran, yes, you will expect a 4 times higher reduction, isn't it? Because of dextran stays, the whole dextran will stay inside the intravascular compartment. So there will be 10% reduction in the PCV. Blood, if you are giving 5 milliliter per kilogram, that means 250 milliliters, so almost half the value. So that's why there is no 10% increase, there is only 5% rise. So why these figures are important? Sometimes when you replace the dextran, okay, replace the dextran, and you are repeating the PCV, if the PCV drop is more than 10%, for example, if the patient is developing around 15% drop, then what you have to suspect? There is associated occult bleeding as well, isn't it? So that's why it is important whether these parameters, the PCV, appropriately changes, or there is some additional component is there. So that's what we have to look for when we are giving this fluid. So that's why before and after giving, we have to repeat the PCV and see whether it is appropriately changed. Right. Then quickly I will rush through the dengue shock syndrome. So dengue shock syndrome, we usually classify whether it is in the pre-shock period or compensated shock or decompensated shock or profound shock, depend on the systolic blood pressure and the pulse pressure. Okay, pulse pressure. So you can see these are available in our guidelines. So if the patient is in the pre-shock, only 250 milliliter bolus is enough. We can give it over 1 hour. But compensated shock, again 500 milliliter needed, but over 1 hour. But decompensated shock, we have to give the boluses as fast as possible. Okay. Profound shock also, we have to give it as fast as possible. So this is how we give the first bolus. Then second bolus depend on the response, whether the PCV is raised or not. If the PCV is raised, we can try for the second time another bolus. If it is not responding, then we have to go for dextran. But if it is responding, then what we have to do is we have to gradually reduce. Like we are given 10 milliliter per kilogram, then 7, then 5, then 3, 1.5. Otherwise, what will happen? They may develop rebound shock later. So to avoid that, we have to reduce the fluid step by step. Likewise, compensated shock, the only difference is we have to give, so decompensated shock, we have to give as fast as possible. Otherwise, the same mechanism is applied. So in case of resistant shock, what we have to do is, we have to look for this ABCS, that is acidosis. Don't do the ABG, the bleeding risk is high. So do the DBG and look for this acidosis. And bleeding we have to look for, and calcium we can do, or if it is not available, we can empirically give calcium gluconate, check the RBS and give glucose as well. Fluid overload, another important part we have to worry. So this is the case, the patient is transferred from a peripheral hospital with a low BP, 80/60, with a heart rate of 120, with a bilateral pleural effusions and ascites, and HCG is high, platelet is low. So here it's a problem, isn't it? If you are giving more and more crystalloid boluses, what will happen? It will further worsen the effusions and ascites, that will compromise the cardiovascular system as well as the respiratory system. So what we have to do? So in this sort of cases, what you can do is, you have to look at the HCT and the hemodynamic status. Depends on that, you can give the treatment. For example, here the hemodynamic parameters are unstable and the patient is having high HCT. So here the choice is, without trying this high volume of normal salines again and again, then we have to go for the dextran, and we can give the midway Lasix after giving dextrans. Okay, likewise we have to deal. So if the hemodynamically stable, usually we wait and watch with the fluid restriction, because they may develop polyuric phase on their own. So we don't need to disturb the physiology. But if the patient is having low PCV and unstable and fluid overload, then we have to consider blood transfusion. So that's how we monitor the, we have to treat the fluid overload. A small difference, I have put a chart comparing the leaking phase and the fluid overload. If the patient is having significant pleural effusion, more than half, that favors the fluid overload rather than the leaking itself. Likewise, gross ascites favors leaking, fluid overload rather than leaking. Likewise, pericardial edema, facial edema, generalized edema favors fluid overload rather than leaking. Pulmonary edema, again, fluid overload. So you should have an idea whether you are dealing with fluid overload or leakage, or sometimes in real case scenarios, usually they have both. Okay, that is the worrying thing. Right, we will come to the discharge part. So these are the ABCD. These are point towards that convalescent. The patient is entering into the convalescent phase. The main important thing you have to ask from the patient is whether patient feels better. That is the most important thing. And the appetite will improve. The patients may develop bradycardia, convulsion rash, and diuresis. And the patient should be fever-free for more than 24 hours without antipyretics. And patient should be 2 days fever-free after, 2 days after recovering from the leakage only we can discharge the patient. And before discharging, the platelet should be in the rising trend and more than 50%. So if all are satisfied, then we can discharge the patients. So these are the convulsion rash. You can remember sometimes it is called pearls in the Red Sea. You can see the white area in the background of reddish. So that's why it is called pearls in the Red Sea, convulsion rash. Here also the convulsion rash is this one. So next 5 minutes, give me 5 minutes, I will finish it off. This is something about the dengue and pregnancy. I will briefly touch on that and I will finish my presentation. So pitfall in dengue fever management, mainly in the history. The patients on admission, the patient may not have fever. So specifically, you have to ask whether the patient had any fever before admitting to the hospital. So that question you should ask. And the abdominal pain specifically, we have to ask. So you may think that the patient is having abdominal pain due to pregnancy itself, or some due to ectopic pregnancy or something, but it may be due to dengue hemorrhagic fever as well. So always consider that possibility. And persistent vomiting you may attribute to pregnancy physiology, but it may be again due to dengue hemorrhagic fever, persistent vomiting. So always correlate with the clinical picture and the trimester. Examination wise, that pregnancy itself will cause some tachycardia, but more than 100 in the absence of fever, always you have to look for cause, especially dengue kind of picture. And usually the pregnant patients are having white pulse pressure, especially in the second trimester. You can see the white pulse pressure. Because of that, we have higher values to consider the compensated shock. In normal people, if it is less than 20 only, we consider as narrow pulse pressure, isn't it? But in pregnancy, less than 25 is considered as narrow pulse pressure, and we have to deal accordingly. And this patient sometimes have low blood pressure because of this ionocaval compression, especially in the patient is in the supine position. So that is called supine hypertensive syndrome. That gravid uterus will compress the vessels, large vessels, and it will cause hypertension. So that's why in pregnant patients, always measure the blood pressure in left lateral positions by putting the cuff on the lateral, left arm. You have to measure the blood pressure. Then pleural effusion, detecting the pleural effusion and ascites may be difficult because the diaphragm is pushed up due to the gravid uterus, and that all bowel loops and all these things are displaced due to the gravid uterus. So that's why it is demonstrating the pleural effusion and ascites would be difficult. Then investigations wise also, it may mislead us because WBC may be high due to the pregnancy itself. So don't think that the patient is having bacterial infection. So it may be dengue as well. So the low PCV usually happens because the plasma volume increases more than the RBC volume. Because of this relative increase of plasma volume, PCV drops during the pregnancy. So just 38 to 40 may indicate that patient is having leakage and dengue hemorrhagic fever. So usually the pregnant patients are having low PCV around 32 or 34. So these values may be higher. But likewise, platelet also may be low. But if it is less than 80,000, it can't be due to gestational thrombocytopenia. We have to think about some other causes like HELLP syndrome or dengue fever. Other things we have to exclude. Likewise, serum albumin is low and fasting blood sugars are non-fasting cholesterol levels are high during pregnancy, so it can't be used to support the diagnosis of dengue hemorrhagic fever as we have seen earlier. And dengue patients are usually having respiratory alkalosis due to pushed up diaphragm and tachypnea. So because of that, even a small reduction in pH, we have to think about the possibility of prolonged shock. Okay, when we are interpreting the ABG. Input output chart wise also, we have to, when we are calculating the weight, we have to calculate for the pre-pregnancy weight rather than the current weight. And they usually have the frequent urination due to vasopressinase secretions by the placenta, and they can have kind of a diabetes insipidus picture. So urine output is not a good marker of degree of shocks in pregnant patients, but it's a good marker in normal non-pregnant patients. Complications wise, pregnant complications may mislead us, and we may miss dengue hemorrhagic fever. Especially we may suspect the ruptured ectopic pregnancy because of the low blood pressure and free fluid in the abdomen. We may think ectopic pregnancy, but if you do the platelet full blood count, it may show low platelet count that may be due to dengue hemorrhagic fever. Likewise, you may think that the patient is having HELLP because of the low platelet and high transaminase, but it can happen with the dengue hemorrhagic fever as well. Likewise, in placental absorption also another problem happens. The dengue the placental absorption happens during the dengue fever, dengue hemorrhagic fever. They are more prone to develop DIC because of the unstable blood and low platelet. Consumptive coagulopathy happens, and they are more prone to develop a DIC. Treatment wise, risk of fluid overload is there because of the low oncotic pressure and high wedge pressure. They are more prone to get fluid overload. So when you are giving blood transfusions or dextran, we have to be very careful. The patient is at risk of developing pulmonary edema. Likewise, during the labor, okay, during the delivery, we should have a low threshold to transfuse. In normal patients, we won't transfuse if the blood loss is less than 500 because of the auto transfusion. That aortocaval compression is released and complete uterine retraction divert around 500 milliliter blood. So because of that, we are not replacing this blood loss. But in case of dengue fever, even a small volume of blood loss we have to replace as this hypotension may be masked, and you may diagnose this dengue hemorrhagic fever only in the later stage. So because of that, we have to consider, we have to have a low threshold to replace blood after delivery. And this is the last slide. And usually it is managed, depends on whether the patient is having dengue fever or dengue hemorrhagic fever, whether it is a complicated pregnancy or uncomplicated pregnancy. Usually dengue fever, whether it is uncomplicated or complicated, usually managed in the obstetric wards, managed by both obstetric and medical team. But if it is dengue hemorrhagic fever, better to manage in the HTU setup. If it is dengue shock syndrome with in a complicated patients, usually managed in the MICU setup with the multidisciplinary team. This one. Usually, according to our guidelines, what they say is all the fever patients should be admitted to the obstetric ward first, and from there they have to put the appropriate referral, including the physician referral, and they have to manage accordingly. That's right. Thank you for your patient listening.
Thank you very much, sir, for that very insightful and very direct presentation on the ABCs of dengue. We have a very few questions to be discussed now. The first question is, how do we differentiate a case of false positive dengue antibody testing comparing with other viral fevers and the COVID-19?
Yeah, so that's what I have already mentioned, that false positive sometimes may happen with the other flavivirus like Japanese encephalitis virus and Zika viruses and some other viruses, but those viruses are very rare, and sometimes it can happen with the severe sepsis also. So in that case, if it is possible, we can do the PCR testing. If the time interval is okay, then we can do it. Otherwise, if it is not a reliable laboratory, then we have to repeat the test from the reliable laboratory. So that's what we can do. But most of the time, actually, we don't need any sort of antigen or antibody testing to differentiate. That I think the clinical picture itself would be very useful to differentiate these entities.
Next question, sir. If a patient is already on any antiplatelets, at what platelet count should we stop antiplatelets in dengue?
That's a good question. Especially if the platelet counts are dropping less than 150,000, and if the drop is kind of drastic, it's better to stop when it is drop less than 150,000. But if it is really indicated, when the platelet counts start to raise, and if the patient didn't develop any sort of major complications, then we can start one antiplatelet. If the patient is on dual antiplatelet, if the patient is in the recovery phase without any previous complication, then we can start once it's more than 100,000, we can start one, and another one we can start when it is more than 150,000, provided the patient didn't develop any sort of hemorrhagic complications during the illness. Yes.
Next question, sir. What are the specific criteria to admit a dengue patient?
I think that I have discussed during my presentation also. The one thing is the platelet count. If the platelet is less than 100,000 in a febrile patients, we have to admit. Or otherwise, dengue suspected patients, even the platelet count between 100 to 150,000, if the drop is dramatic, the previous day it was 250 and the next day it is 140, that drop is dramatic. So in that case, again, we can admit the patient. That is based on the platelet count. Other one is based on the symptom and signs that is suggestive of pre-shock and shock. For example, abdominal pain and persistent vomiting, giddiness, and all sort of things. The prolonged capillary refilling time or postural hypotension. All these features that is suggestive of pre-shock or shock. Then we have to admit. The third thing is high-risk patients. High-risk patients, even in the absence of the low platelet or this one, if the patient is having fever and kind of a dengue outbreak time, if there's any contact history is there, then we have to have a low threshold to admit pregnant patient, elderly patients, and obesity patients, and patients with multiple comorbidities like diabetes, ischemic heart disease, and that hemoglobin disorders like thalassemia, we have to admit. And the patients with the adverse social circumstances also, we have to admit. The patient is living alone or far from the healthcare facilities or transport facilities, again we have to admit. This pregnant patient also, I think one more point I want to emphasize, we don't need to wait until third day to do this test. We have to do the test even on day 1 of fever or day 2. We have to do the full blood count, and we have to detect all these things early, and we have to manage, because dengue in pregnancy is a problematic thing, and we have to manage appropriately with the multidisciplinary team approach. Otherwise, the outcome would be poor. Yes.
Next question, sir. Is there any role of inotropes in dengue shock?
Yeah, so the first thing is we will resuscitate with the fluid. Depends on whether the patient is having fluid overload features or not. We will replace with the crystalloid first, and then dextrans. And if the patient is not picking up, then obviously we have to go for inotropes, including noradrenaline and some cardiac inotropic support as well. So if the patient is not responding the fluid resuscitation, yes, we have to go for inotropes. There's a place.
Next question, sir. We were talking about pregnancy and dengue fever a lot. Our audience wants to know a bit of a summary on what warning signs should we keep an eye on in our pregnancy patients who presents to us with fever.
Yeah, so always, in Sri Lanka, like all the pyroxia unknown origin patients, until proven otherwise, TB. Likewise, in pregnant patients also presenting with fever, what you have to think is, until proven otherwise, it is dengue fever. So pregnant patients, please examine and please ask specific questions like, abdominal pain, persistent vomiting, vomiting, it's a normal thing in the first trimester, but after settling again, in the 20th week or 22nd weeks, the patient is developing vomiting, persistent vomiting without any obvious cause, then we have to think about that. Likewise, dizziness, fever with dizziness, fever with abdominal pain, all these features may suggest the patient is having dengue fever or dengue hemorrhagic fever, and then measure the blood pressure in appropriate position and look for any narrow pulse pressure or tachycardia. Those features we have to look for, the prolonged capillary filling time, and the investigations also sometimes it's difficult to diagnose because of this some pregnancy related changes that happens with the full blood count and PCV. So that's why if necessary you can do the NS1 test also and antibodies to aid our diagnosis. And while you are interpreting, always think about that pitfalls I have discussed during the investigation part. Always look for that one, then you can fairly diagnose this dengue without any problems. Yes.
So I think that's all the questions we have to share, to discuss today. We don't have much time left. And on behalf of the GMOA Shri Knowledge Academy and the College of Internal Medicine, I would like to thank you for the very extensive and very clear and very specific lecture on summarizing how to manage dengue patients, especially in a peripheral setting, and what warning signs and what specific signs we need to keep our mind into during this very epidemic season of viral fevers. And our participants, we really apologize for the fact that we could not admit all of y'all for today's lecture, but we were able to stream it live on YouTube, and we hope that you all joined with us. Thank you again for spending this Sunday with us, and we hope to see you again next Sunday with a new topic, a new lecture, and in view of updating our knowledge in our current practice. Thank you, sir, and thank you, everyone.
Thanks. Thanks.